So first of all, thank you for the opportunity. And my talk is on lipid, the changing paradigms in the lipid lowering therapy. I know it's a pre-lunch session, and I and Abhishek both are from Zydus. We will be quite mindful in talking, make it quite comprehensive and not bore you for a long period. So what's the flow of the slides? What I do is we'll discuss first thing, that how low we can go in the lipid management. The focusing point is a high risk ASCVD patients only. How early we should start escalating our therapy. What's the role of new agent inclisiran in the management? What are the datas? And which are the appropriate indications or the selection, how you are going to select your patients. Now this slide is very pertinent, whether it's a medicine or a quantum science. So I think it's not seen, but when we travel from what is known to what is unknown, our understanding of what is known should be quite mature. If you fail to achieve that, I think in that scenario, we are not going to create wonders in what is unknown. So what do we know? So we know this, that LDL is the main villain. Increase of LDL by 1 millimole will bring mortality or cardiovascular mortality almost by 20%. And with the statin era, what we have learned, if we can reduce even 10 mg per deciliter, the cardiovascular mortality will go down by almost 5 to 8%. We have understood in the recent era that what is cumulative exposure of LDL. So what is cumulative exposure is your age and your LDL value. You multiply, and that once it reaches to a threshold of 5,000, you can see that your risk, which is quite less of around 1%, will start increasing exponentially. So what's its impact? So supposedly a patient who is at around 20 years had LDL of 200. If you calculate his cumulative exposure, it will almost become 4,000. So by 25 years, it will reach to a peak or the threshold of 5,000. So after 25, his risk of developing a cardiovascular event almost from a 1% rises to 60%. As the number of years he is exposed to that LDL value will bring more and more cardiovascular mortality. So most of the time, this patient before 40, they tend to develop a cardiovascular event. And what you achieve by lipid lowering therapy is you delay the progression of cardiovascular disease to the next 15 to 20 years. So the person who has LDL of around 200 at 20, if you don't treat that patients, the mean age at which they present to for myocardial infarction is around 35 to 40. And if you treat them aggressively, I think you'll reach at an average age of 60. So you are delaying the disease, delaying the event by 15 to 20 years. So that is what we have understood. So at that note, now we will focus the patients who are still at a very high risk of the recurrence events, and that is Achilles heel for the most of the physicians and the cardiologists. The residual risk or the recurrence of the event almost been seen nowadays is around 15 to 20% of the patients. Now what are very high risk patients? And very high risk patients are the patients who are here. So those who have established cardiovascular disease, occlusive, non-occlusive disease, heterozygous familial hypercholesterolemia, calcium score. This is a lipid association guideline. What they say is around 100 to 299. Calcium score in an Indian patient is a very high risk category. A diabetic patients with almost end organ damage, a diabetic patients with almost 2 risk factors, they are at a very high risk patients. Those who have established cardiovascular disease with one high risk feature, calcium score of more than 200, they are extremely high risk patients. Those patients who have ASCVD and the recurrence of the event in first 2 years, they are a category B, very high risk patients. And there are certain group of patients when you try everything, you lower the lipid less than 30, and then still they have an event. And these are the patients who are called as category C of extremely high risk patients. Now what are the guidelines which was recommended? So Lipid Association India has given some targets. So for a very high risk group, the LDL target is less than 50. Extremely high risk group, less than 50 is preferred, but you can go less than 30. And for an extremely high risk category C, where you achieve a target of less than 30 and still a recurrence of the event has happened, there are recommendations that you can still go to almost 10 to 15. Now, these are the Indian guidelines, and almost CSI guidelines and the Lipid Association, they all agree on that. But even the European Society guidelines also endorses this view that LDL reduction of more than 50 or should be achieved a target of less than 55, and those patients who have recurrence of event, we should go down to less than 40. The second question is, now you know the thresholds. Second is how early you should strike to prevent this recurrence of the event. If you look at most of the data, you'll see that first 90 to 100 days, it is a crucial time because most of the events, recurrence of event, they happen during that period. So almost 10% of the patient in current practice, we see that they reach to you with some form of cardiovascular complication. So strike early, strike strong is the concept. So what is been advised by the European Society, and now we also have Indian guidelines also, that a patient comes to you with the ACS, you have a lipid profile done. Now, previously, there were a lot of experts and guidelines, they used to recommend that because you get your lipid at the event of ACS, you will not achieve anything because as such you are going to load your patient with the statin. Statin is apart from lipid lowering as anti-inflammatory and other pleiotropic agents. So why a lipid profile should be done? The lipid profile, and second argument was as such your LDL is going to be a falsely low during the first 24 hours of acute coronary syndrome. So you are not going to achieve anything. But the argument is now you want to strike early, and supposedly your patient's LDL is higher. Even you know that it is going to be a falsely low, but still it is higher, you have an opportunity to strike early and devise your strategy. So first, get a lipid profile done and start a therapy. Now a patient with ACS, and then comes this point. So patient is not taking his lipid naive patient, you can start high intensity statin therapy, re-evaluate them at 4 to 6 weeks, the targets are not achieved, you still escalate the therapy. If the patient is taking low dose of statin, you can make it to a high dose of statin. The initiation of ezetimibe with the high dose of statin is still a class 2A indication, but Indian guidelines, they still endorse that you should start a combination of high dose of statin and lipid. What if your patient is already on high dose of statin? Then you look at your value. If the targets are achieved, your targets are less than 55, you continue the same dose, or you can, a patient who has come early, you can still reduce to less than 40 and ezetimibe. If the targets are not less than 55, you add a ezetimibe. And the patient, if he is already on high dose of statin, on ezetimibe, now this is the patient, you have indication to start this therapy as early as possible. So Indian paper is already there. So what they recommended, that the patient comes with the ACS, get lipid profile done, lower therapy only for the CKD patient and elderly patient, lower them with rosuvastatin 40 with ezetimibe 10 or atorva 80 with ezetimibe, evaluate them at 4 to 6 weeks, the targets are achieved, you continue the same therapy. If the targets are not achieved, you re-evaluate and start with the newer agents. If the patient's targets are not achieved, you calculate. Now, by the various trials, we have understood that what you achieve with the maximum dose of statin therapy, you are taking 40 mg rosuvastatin, you expect that the LDL value will go down by almost 55 to 60% if the patient remains compliant. You add ezetimibe, you add further 10%, some patients they respond better, maybe 15%, you add bempedoic acid, you can add still 10% more. So if your basal LDL values by this calculation is not going to go at 4 weeks less than 55 or less than 40, whatever your targets are, in this category of patient, you can think of these newer molecules or aggressive lipid management strategy. So where does this new agent inclisiran fits? So what is inclisiran? So first of all, we all know what is PCSK9. So PCSK9 is a protein which is produced in the liver. And what is the role of this PCSK9? It binds with the LDL receptor, causes destruction of the LDL. So we have now a lesser number of LDL receptors on the liver surface, and the receptors are less, the circulating LDL value is high, and this makes patient more prone to your cardiovascular disease. We already had almost for last 5 to 7 years the monoclonal antibodies, that is PCSK9 inhibitors. What they do, they bind to Fc receptor portion of this LDL receptor, and the interaction between this PCSK9 on the LDL receptor is prevented. So that happens on the surface. Now what this inclisiran does? Inclisiran enters the cell, makes a complex with the messenger RNA, which basically forms this molecule and causes destruction of this messenger RNA. So the first agent, it strikes on the surface like an action on LOC. The second agent goes inside, strikes back and causes inhibition. And that is why you achieve a longer action. So statins, you need to take it for 365 years a day. These monoclonal antibodies, you should at least need, you need at least 26 doses per year, 26 doses per year, because if 420 mg doses are not available, you have to split your doses to 14 days therapy. Whereas this therapy with inclisiran, you need only 2 doses. First is 0, 3 and then every 6 monthly. So that is an added advantage. The compliance increases. Do we have evidence? That is an important question. Yes, we have evidence. So Orion 9 was a phase 2. Orion 910 was a phase 3 studies. Heterozygous familial cholesterolemia patients were taken. In 9 and 10, they were taken those patients who have established cardiovascular disease or those who have very high cardiovascular risk. And in that, what they achieved is this. 74% of the patient, they achieved your goal of less than 50%. Wonderful. And the sustained almost at the end of 500 days, almost 50% to 60% reduction of LDL-C was noted. Do we have a data for Asian patient? Yes, we have a data for Asian patient. The same results were repeated. In fact, here's 57 to 56% reduction at 1 year of LDL, 70% again. Patient achieved the LDL reduction. Importantly comes here is you have associated lipoprotein small a reduction by 40% for the first year. Do we have a drug for lipoprotein? At present, no. Probably in future, yes. We know lipoprotein small a is a culprit. It causes greater cardiovascular events in Indian subset of patients. So this is an advantage. This is again a third study where patients who failed to achieve the targets at the LDL levels more than 70, the therapy was initiated. Again, the same result. 70% of the patients, they achieved the goal, and almost 50 to 55% reduction from a baseline LDL value, the reduction was noted. So in short, basically, the inclisiran is very safe, very effective, almost no dose requirement, especially in mild to moderate and senior renal dysfunction. Hepatic mild to moderate, you are safe. Your data of almost 6.8 years, more than 12,000 patients were there. And those patients, again, the query was, you have antibody against this molecule, what will happen? So it was found that the effect lasts. No drug interaction which is noted. Do you have data for cardiovascular mortality? I think for most of the molecule, we asked this question. And that is an unknown territory. Still, we'll have waiting for the results. They will come by 2027. Where they look into a reduction in all cause of mortality and the cardiovascular death. So we have to wait for that. The one trial will end by 2027, second will be in 2029. Again, like statin, they are working whether the plaque volume reduces or not, what happens to the intravascular coronary plaque volume. So this study will be available by 2027. Inclisiran stands as far as the indications are concerned. So there are various societies we all know, and most of them have a same consensus that if at the end of 4 weeks your LDL targets are not achieved, the inclisiran has now positioned itself in such a way that you can either add inclisiran, either a PCSK9 inhibitor, or you try bempedoic acid. The problem with the bempedoic acid is that it works in the primary prevention. You have last trial which has shown that it works better in primary prevention, but not in the secondary prevention. We don't have an answer for that. And once the LDL values are less than 70, the relative effect of bempedoic acid in reduction of your baseline LDL slightly decreases. There, a PCSK9 and inclisiran remains a drug of choice. UK guidelines, again, US guidelines, they also feed those patients who are having a statin intolerance, and it is not uncommon. You are having high dose of statin, high dose of bempedoic acid of 180, ezetimibe, myalgias are going to be common, and in those patients, sometimes you need to de-escalate the therapy, your goals will be shattered, and in that condition also, you can use either PCSK9 or inclisiran. So which are the classical patients you should initiate the therapy? So I have an example, one patient who has angioplasty, a very young patient, LDL is 120 on atorvastatin ezetimibe. So somebody say, why not a bempedoic acid? Yeah, what we will achieve by adding a bempedoic acid? 10% reduction. So what is LDL going to be at the end of 4 weeks? It is around 100. So you will not achieve a target. And there, either you can choose a inclisiran. A second patient, a complex intervention on rosuvastatin 40, ezetimibe 10, LDL is 145. Now these are the patients who are not responding to very high dose. You should investigate for a heterozygous pattern, but of course adding bempedoic acid is not going to solve your problem. Injectable preparations are needed. And a third patient, ezetimibe, rosuvastatin, bempedoic acid, LPA is high, LDL is 110. Now you have no option left, but you have to choose an injectable preparation. So now inclisiran has position in blood in such a condition, such a state that this class of patients, they are very high risk patients, extremely high risk category of patients. Your goals are not achieved. You want sustained reduction of more than 50%, and for prolonged period. I think patient comfort becomes very important. Patient is not, because already taking multiple medications, they want to ease the burden, pill burden. I think this therapy helps. So in short, inclisiran is safe, effective, 50% baseline LDL reduction is noted, the results are sustained, we have good safety data, the injections are well tolerated. So I end with my talk here, and I think open for the discussion.